And the other option is the flexor way, is that the deforming strength is a flexor. And so this way, it produces a pump that flexors the joint. And here we have a patient that, depending on the deformity or the time they've got this deformity, so mainly in the phases of, so if you ask the patient to be this way, so the deformity is increased. And so the deforming strengths are mainly flexor in this patient. And we can have mixed cases. So there are deforming strengths that can be one way or the other. So in the anyway, when we've got this kind of deformity, like here in a claw, so the deforming strength are dynamics, and with the time, the passive structures, so they also will exert this way, and so it would going to grow, so to provoke this deformation, and so it's going to reduce the space in the joint, and that will produce a progressive stiffness, and also it's going to shorten the real length of the toe. So this idea takes us, or the way we understand this, is that all the pathology. So we've got something that we cannot even share among the bone and the soft parts. So it's something that simply they do not match. The length of the bone when this person was born without a deformity is losing little by little this length due to deformation, and it produces a deformity where there is something that simply does not match, as we say. So, what is the treatment that we can have for this, or the better treatment we have based on this idea to approach that from 2 points of view to um, enlarge the soft tissues or to short them? So that is a free body diagram. This in this red arrow we see here with the strength, the tension is the stress, and we see a flexor plate, and also we see the rear strength and everything which is provoked by the flexors. And this arrow can be bigger or smaller depending on the flexors. And we see here the metatarsal head. And once we are in this situation, then net movement is dorsiflexion. So the patient is going to have this movement that is impossible to control. So what do we propose? If we try to stabilize, we do an osteotomy, an aching surgery with a distal branch, and we are able to realign tendon's position in a way that we can neutralize the deforming strengths that in this very moment we've got in this joint. And if we do it, the strength is going to be smaller, and the strength will also be reduced. And we're going to have a shortening of the initial position that we had at the beginning of this phalanx, because we make it shorter. And so it is a case of a patient with a digital deformation with a shortening of the toe. And if I am able to enlarge it, so if I just put it right, I'm not enlarging that, but just leaving it in a distal position. so I can't maybe make an enlargement of ligaments. But the toe will be shorter than the first position. So doing this surgery, I can make it functional without enlarging the toe. This is a case of a young patient which was operated some time ago of a kind of ostomy with a very rigid osteotomy. And he wanted to be reoperated. And I said, I can put it in a a straight position, but I'm not going to make it bigger. I can just leave it in this length. I know that aesthetically is horrible, and for that I can change the second or the third toe or the first one. That was exactly his baseline, and my way to explain that is that I can enlarge the joint, but the final length of the finger will be the same. I know that aesthetically that's not going to be the best, but the other things you can do is with the shorter, the other um, toes. I also recommended to shorten the first one. He didn't want to, and so what we did was just to put it right without enlarging, because this way it is going to be a good position at the end. And at the end of the day, he recognized that maybe uh, surgery on the first toe would also have could have been a good idea. So from the surgical point of view, it's quite easy, and we work on the proximal phalanx. It's not a big incision, and the first thing you find is this tensor. You can just put in one side. The first cut that would be parallel to the proximal phalanx. The second one is plant is flexor plantar, and we can just remove this piece of the bone. I can also stabilize that with a Kirchner needle. This osteotomy also allowed us to correct deformities on transversal plane, and so we can just align the tendons on the metatarsophalangeal um, joint. So it is it is comes from the classical surgery that is based on this idea, because we can consider osteotomy correcting the transversal side. Here we've got a patient with Alloxer virus as a big evolution. And my option here was an arthrodesis on the first joint together with osteotomy this way that was able to make an apposition on the toes. It's the same concept as in mixed surgery. And despite the joint was not corrected, it is true that after 1 year, it was stabilized. And even at the second year, didn't find a deviation. So we were able to center the um, the flexors, and it is difficult to have a feature luxation. Here we've got a position at the sixth on the sixth mouth, and the position here we've got the dorsal position. A specific case, a quite special case of a digital deformation arrives when there is uh, a lesion, when there is an injury, because here the shortening is quite severe and it's very big. And this idea can also be applied in the treatment of this patient. And Samuel Baruch um, showed us his MS point is the maximum shortening point. It is where you have to carry out the osteotomy, where to correct, and so to try to correct this problem. And what we propose, or what I want to propose here, is another point that we correct. We just called PSM. What is the point of a stretch maximum? Regarding less of what you can do on surgery or the way you do it, you shouldn't just leave one and two longer than over or passing over this point, because it could come back, or you can have another problem in the future. So it is a point where you can do metatarsal corrections. But try the toe not to go over this point. So that would be a patient we operated with a reconstruction with a MS point, that is the one called Trevaru. But for me, it also have a PMS point. And so shouldn't at the end of the treatment, the the finger cannot be longer than this point. That was the initial point. So I can make corrections, but I should keep this position. So it is a quite severe uh, case. In this case, it was that big that I projected to the dorsal Z, and with zitoplasty, here it is the joint that we opened. We removed the ligament, the lateral ligament. There is a break in the plate. So the plate is broken. It's something we really knew through the radiography, the X-ray. But in this case, we had to do a correction of the metatarsal head, but also we needed to calculate the maximum point of where the finger will arrive. And from this moment, we can start with the surgery. And so the scheme for this surgery is exactly the same as we saw before. So this patient lost the flexor plate, the strength given by the flexor plate. And this patient needs osteotomy, a long one of 1 centimeter approximately. So to correct the deformity a little bit less in the second, a little bit less in the third one. And in this way, we did a partial resection on the head. And the final position is that one. You can see that in this case, the fingers are a little bit more stretched due to the release of soft parts that we did. But and we also cut the flexor tendons. We were able to enlarge it a little bit. But it's normally it's not a common point. My idea is not to leave it longer than it was. So it should kept in the first position. And that is the final position. And this applied to that can be applied to all the surgeries. We can correct metatarsal parable and also the deformities with the same procedure. And after 1 year, the patient keeps the correction, and the correction point, this PSM of maximum strength, or the stretching maximum, sorry. So the idea is not to leave the finger longer than this stretching maximum point. Here we've got another case of deformities, and we can do this osteotomy in the same way, correcting the same plate, the same site, and leaving the initial length. And now, what are my conclusions? We can understand digital deformities from a paradigm of an imbalance, and there we can approach enlarging soft bodies or soft parts, or reducing the bone parts. We cannot adjust that through an osteotomy on the proximal phalanx with a maniac. With a missed surgery, can correct all the planes, abduction, and so on. And the concept of point of stretching maximum will show us what is the length that we should keep. So indeed, during this readjustment, and in my experience, it avoids future problems. So it's a problem of the first of the force. And may the force go with you. So thank you very much. And now we'll give the floor to Bernard Pasterit to speak about surgery alternatives. So, Mr. Bernard, you've got the floor.
Hello, good afternoon. Thank you very much for inviting me to present here. I know it's not the best time after lunch, so I hope you don't fall asleep. But the idea is talking about different ideas of the correction of the plantar plate, which is critical for the metatarsophalangeal joints, and together with Jordi and all of us nerds, feet nerds, it's important for us to understand the critical role it plays and with the continuity with the fascia and this final and ending insertion in the plantar place at the foot of the phalanx. Now, so the idea is trying to get to the metatarsian, and lately I've seen publications and articles, and there is a complex group of tendons together with the plate, both in the plantar area. This I love this research, and I suggest you check this research on the extensor system and all the connections with the plate. So we need to have a balance between these strengths and the forces from the plantar and the dorsal area of the metatarsophalangeal joint. So there is a space that can lead to luxation. Can be acute, depending on the cases. It will have an impact on the second ray, and over solicitations, mechanical over solicitations, especially in the third rocker, are going to be one of the main reasons of this etiopathogenics. And so this is this ruptures associated to sport are going to be less frequent. And this, we can see the capsule and the plate, and repeating again and again this movement, we'll see an erosion on the plantar part of this plate, and it will end up by breaking and rupturing the plate, and then this is when luxation, or it will develop, it will end up in a luxation. This is a frozen foot, and we've seen how the plate is able to stabilize the metatarsophalangeal mobility. And what we did is and you can see clearly in this image, when there's an injury of this plate, we will be there's many chances to so that the patient develops this luxation. So it's important to understand how this works. The patient will refer metatarsophalangeal pain, stiffness, lack of mobility, So it's they find like a bit of hardness in the third rocker, any bad movement, maybe they went out for a walk and there was an unbalance, and so as soon as we get a subluxation, this will develop from metatarsalgia to on the third rocker to the second rocker. So we can see in stage 0, there's not deformed. We can see swelling, and second phase is slight deformation, and it goes gradually to big deformation. So different injuries, usual area where where the plate rupture takes place in the base of the phalanx, and we can see the situation is progressive. It gets worse and worse, and we can carry out the paper pull-out test, and the foot should be able to hold the paper and get it off the floor. And if there is loss of strength and being able to lift it up, that's when we start seeing. And also we can perform the Lachman test, which is what we're seeing on the video. This has a very high specificity and sensibility, and so in order to assess our patients, what we like using is simple radiology, second metatarsion, where there's more pressure in this, and it's prone to rupture. And we're talking about soft tissue or soft part, so consider whether we use the ultrasound or different options. And we've recently published, together with Javier and a few foot nerds, in this Spanish magazine, when we talk about the ultrasound assessment, and it's our preference, and we much prefer the ultrasound over CAT scan or MRI. And being able to assess in dynamically assess, I think it is very powerful when it comes to diagnostics. And of course, MRI is also, we can also use it for diagnostics, but it's good to have always feedback, good communication with the radiologist, ask them to, if we can get the as maximum number of cuts and as close as we can to get more definition, because if the cuts are way too separated, then we are lacking some parts. There's some cuts in between. So these ultrasounds in 3D, we get beautiful images in high quality, allowing us to classify the different degrees and stages. And so this is an anatomic aspect which is relevant. And this, we have this central synovial recess, and we can check it with the ultrasound, and this can be normal. The experience of the radiologist is paramount here for the good teamwork. And so the question is, if you consider there's some deformity or disfigurement, it's important to treat it. And Do you think that this can imply other acute injuries and associated to other injuries and other pathologies? Also, maybe we can consider some therapeutic options, maybe and plantar or foot orthesis, and we continue to see all these ruptures, and this is it's important to have this previous blockage so that it doesn't hurt the patient. And the last trend at the moment in is regenerative therapy with stem cells. A friend of mine that it's devoted to growing and culture of stem cells, and we do this. We extract them via liposuction, and this it can make sense to use this and other surgery options to repair and restore the ligaments. And we tend to, or in the past, we used plastics to stabilize, but nowadays more and more we tend to use anatomic solutions, and amongst the usual classical ways to restore is the isolated veil or the flexor to extensor tendon transfer. And amongst the anatomic repairings, we can have direct suture of the plantar plate, whether it's dorsal or plantar. The flexor to extensor isolated is not anatomic. Lately, we've seen in the market new devices like this one, Tino Tac from Paragon, which is basically a staple that allowing us, it does clip the tensor in a way, and the non-anatomical repairings, we know the whale, simple whale, has a tendency to leave some floating fingers, and we've seen some studies being published about the improvement of the symptoms. Simple whale, we know that due to its design, the rotational center in the head, they end up being dorsiflexors, and the head creates more of a flexor, a plantar flexion. So it favors the or yeah, it's likely that we get floating fingers. And so what would be other options? Repairing or not repairing the plate. We do a whale, and hopefully the plate would heal by itself. We can discuss about this later if you like. In any case, metatarsophalangeal luxation do not reduce, and are not reduced. So my question is, in any joint orthopedic treatment of any full luxation of any joint is reduction. So why do we think that leaving a luxated articulation in the foot, it's normal? So methods like Haspel would be a transversal osteotomy, so that we can remove a bit of a strengthen. We can maybe just apply this method in patients with very, very little, very low mobility, and more like a palliative surgery. Now, Javi was talking about the MS point, which is important when it comes to reduction, to take the metatarsophalangeal head backwards. And if we consider where we want to leave the metatarsophalangeal, it's very helpful. So we performed a study in 154 feet. 56 of them had gone through whale and flexor tendon transfer surgery. 99 of them hadn't had surgery, and we saw no major significance. So they came up to the conclusion that there was no need to operate them. So with the flexor twist tensor, we had out of 64 feet, about 40% dorsal flexion, 30% improved in a way. With the suture of plantar plate, we see that there is an improvement, statistically significant, with less pain, stability, and more patient satisfaction. However, because we are devoted to private practice, every time we do something to improve that structure, it can be interesting. And with anatomic repairings, the flexor to extensor, we don't use it so much for anatomic suture. This article, it's very interesting because they realized they had better results and with a whale osteotomy associated to shrinkage and tissue vaporing, and they had better results in stage 2 and 3 because they did plate repairing, even though they had a worse of an injury. They had better results because they were repairing the plate. In this research, this clinical trial with 86 patients, we have significant statistics with a direct repairing of the plantar plate repairing. It was being discussed this morning in the adenopathy roundtable that it's important for them to have an activity. And my apologies. Now, anatomic repairings improve stability, and we can have better control in 3 dimensions. So it's important to associate, if needed be, the suture of the collateral ligaments. Counter indications or side effects, there can be some swelling and joint pain. So carrying out more sutures can increase the swelling and the pain. So this is something we need to watch out for. For direct repairing through the plantar area, I would save this for very difficult cases. It's something we can do. It's easy to perform. And if we move the tensor flexors, we can have easy access. However, for initial stages, it's better to use whale. And we've also has been discovered an astrosopia, arthroscopy, this shrinkage, and we can see this. The plate is injured, and we can do some shrinkage with the aim of trying to repair and have this being removed. And we can do also direct repairings through the dorsal area, and so if you always perform a whale osteotomy, and this also will allow for us to open a bit more space to better suture the plantar plate. We have more and more devices that help us perform this Viper, the previous one, devices that help you in very narrow areas, and like this one, it's called the pork tail. That will help you in narrow spaces. And then we can do some drilling here some holes. We have this system, this paratrooper from Paragon, with a bit of small pieces of silicone to enlarge and improve the traction. Uh, and what we do is enter through the dorsal way, and if there's some luxation, we can do some thetaplastia or capsulotomy and Z-plastia, as we were saying. And so this is important to have a Manglamery elevator to separate the proximal part from the plantar plate. And with the MS, we were talking about the degree of shortening that we needed, and that was required. We can use the temporary KW to be able to have access to the plantar plate, and here we can start with the suture. We perform some puncture to be able to uh, insert these threads and proceed. We also have some tutors that are similar to the ears of Shrek, this cartoon, and then it would help us to later perform the osteotomy. And we also can do this reduction of the foot with a certain plantar flexion, and then we do this knots on the dorsal side in order to stabilize this. This functional bandage I'm really comfortable with. For a bit more advanced, as in stage 3, we can do using threads and neat, and is the internal threads, aiming at not really replacing the plate, because we know that any element that is not biological will end up breaking, and the threads will end up breaking. And the idea is to give it more stability and reducing the traction in the plate for Mother Nature to be able to correct and improve the scarring and the healing. And so we can do augmentation with the internal brace or using the tender transfer extensor. Also, it is important to give some stability to the plantar plate as well as the collaterals. Here we do this dorsal portal, we get the extensor, we cut it, and we drill and make a hole in the phalanx space and also in the metatarsian, and we bring this extensor for it to work as a collateral ligament plastia, and then we'll use the screws. And it's important to have the correction in both sagittal and coronal planes. And the post-op shoes, they have to be flat, functional bench to help with plantar flexion, and you need to wait about 4 to 6 months for rehabilitation. If we see after 8 or 10 months there's some deformity, we can then just do some adjusting. It's regarding the conclusion, this is a progressive pathology exploration through images or imaging exploration. It's good. It can provide us with a lot of information regarding the type of rupture, and we need to adapt the treatment to every patient. And as usual, the most important thing is to follow the indications of the patient when it comes to when to proceed with the repairs, more than regarding the materials. Thank you very much for your interesting presentation. And now let's move on to the next presentation of Sergio Mirages Ruiz, who is going to talk about decompression longitudinal in surgery of hallux valve.
Hi, good afternoon. Valgus surgery, we start with this initial moment. And what we want to do, because it is clear that we have to carry out an osteotomy, or at least to move the head in a lateral way, so to get this other anatomy configuration. So we want to correct the deformity and to change the strengths. What is not that clear in literature is that in the same transversal plane, where to put this metatarsal head is the one here, the other way around, how to do it. So for the same patient, so the final result of intervention about reverse, so I should leave that in one order. So not from my point of view. So here I want to say, we want to describe what happens depending on where we leave the because the interaction of the tendons of the first and the dorsal head will be different. We're going to have a difference in between the head strands. My colleagues already explained the EMS point of Salvador is the only author who describes what the dorsal head. He defends what it has behind the MS point. To the first radio, it is also on the maximal station point, proximal area onto these pellets. You can see these three bodies diagram. We can see place the head. We put here the different parts of what you can see also the sesamoid and we can see the strong union of these sesamoids and proximal. And we also mark the length on the and up to the interjoint, and that's what we do as point. If regardless of the procedure we do, we place the hand in this position. Even farther, so when we reduce the finger, reduce sorry, the toe, we're going to have two things. On one hand, the distance between the sesamoids and proximal territory will be bigger. It's mainly the perineal sesamoid. And obviously, it's not going to just keep in this position, but they will just go to the base, with the base of the phalanx, proximal phalanx. And so the structure that we can insert in there, or they are there with suffer tensile strength, and especially the lateral fasciculum of the short extension. Because it is a noid, that will be, that's obviously we replace them with these rare strains that is balanced will produce a total strength on the toe. But the way that will provoke the relapse of this deformity. If this strength cannot deform the joint, so for instance, these strength vectors which is up that will produce more strength with more stiffness, degeneration, and so on. And the second situation that can arise with this configuration is that the length can be increased up to the interphalanx joint. And so these structures that we insert in the phalanx will increase the stress and will provoke more compression strength on this compression. situations can be clearly seen this example. This patient, we had this scar osteotomy where we did not decompress enough and we just released the lateral fasciculum. After the operation, in the post-operatory, we can see how deformity has been corrected. After 2 months later, we can see the first metatarsal outpatient is bigger. Some of it appear and in 7 months later, we see the situation is even worse. The relapse is bigger. And 18 months later, we see how it is going to be exactly the same. So in the perspective of time, we can understand what happens in this case. And right after the surgery, despite the radiography is okay, as we cannot see that there was a bigger tension, bigger stress here. And so it was creating an abduction stress. And 2 months later, we can see how deformation starts. And we see the relapse with the time. And we see that the big phalanx comes into the metatarsal space. Lateral fasciculum of the short tensor is relaxed and provokes less strength. But right to control deformity. So 7 months later, wait, in this moment, we can understand that the tensile strength of the tensor, the short tensor, has been balanced with the middle short fasciculum because 18 months later, deformity is the same, or at least, sorry for that, or at least this stress and balance was compensated by the internal collateral ligament. In this case, it's quite similar to a good decompression, which released the suspensor ligament. And during the right after the surgery, we can see that the deformity has been corrected. 3 months, so 3 weeks later, we see the relapse once again in the deformity. So 2 weeks later, we decided to release the lateral fasciculum of short data. So what, so what it happens is the same as before. Because the distance between the samoid and the base of the phalanx is kept balance is the same. Up to the moment we released the lateral fasciculum on the short tendon. And this moment is the distance appears. And 11 years later, we can see how this joint is in Coming back to the three bodies diagram, we can see here our anatomy references the this point. And imagine that the procedure we place metatarsal head in this position when we reduce the proximal phalanx, so we can see that the distance between the samoids is not bigger, there's not bigger tension, bigger stress, and so there is no moment of pathology strength. Fact that fasciculum, the short tendon has no extension, there's no tension, there's no stress at all. And we also see that we do not increase the length from the base of the phalanx till the base of the first metatarsal till the interphalanx joint. Actually, we depend on the proximal phalanx length. If it is quite long, we can't compensate. You had some very good videos in all the computers, but it's impossible to run a computer. So I will explain to you what we did here. So I will try to do my best. The only videos that can work is the fluoroscopies. So here we was just the traction So when we carry out a good decompression, it is good if we can to carry it out with the strength. When we've got dorsal limita- limitation, so when we decompress, as all these soft bodies relax, we would get we would gain some flexion degrees. Here we had three videos. You can see that when we do dorsal flexion of the toe, if we have the high bubbles, it's going to, it's going to be seen. So when we carry out this release and we do the dorsal flexion of the toe, it is improved and there is no problem. It is much more evident when we do this compression osteotomy. So, there is, so it works properly. There is no case of pronation. And here we could look at the flexion on the toe. So once we carry out, we see if we have a bigger flexion. But when we do this lateral plantar release, when we do soft part, we can show that we can see that we can do bigger abduction. So when we carry it out, it's not different. So if we put some doubts, we should stop do the decompression osteotomy and show it and try again because we see that we gain some correction degrees. I can show you that the videos were wonderful. So in this video, what we do is simulating it's a simulation. And it helps to, replacing sesamoids. Now we're going to see some examples of compression. In the case of 2010, so we did here an osteotomy, just right behind MS point, and also a release. And you can see how some 15 years later, the joint is perfectly corrected. This case is a quite similar one. Here we had the MS point. We applied the same concept in a way that we short metatarsal so as to be at the high of MS point. And in the right after the surgery, in this case, we can understand that, and thanks to literature, we know that it exists a very big possibility of relapse because we've got more than 30 degrees here. Sesamoids are had to be reduced after surgery, and when we carry it out, we didn't bear in mind the metatarsal pronation nor sesamoids. I had the opportunity to carry out near X-ray some 2 years, so 2 months, 2 weeks ago. And on the actual case that we have been working on all this thing so long, in this case radio, we have this MS point. But if we only bear in mind the shorter ones, the MS point would be the maximum relaxation of the second toe. So we need to strength to carry out this parabolic and and so the one that needs it to be shorter, that's what we do. So in this case, it was the second. And so we carried out with another surgeon even bigger, it shows how to correct it. With the scarf or slot, and if we carry it out, this fixed fragment, the one we do not move, we get this instance of intertarsal angle. It's the same. So I'm talking about the angle. Intertarsal angle should be exactly the same. As you can see, it is shorter. If we put it one on the other, over the other, this area here will be the correction degrees that we got thanks to the part that we could produce. So, and it's obviously provoking, which you can see on the screen. And we can't show that when we carry out an orthodox. We do not do osteotomy, we don't do displacement on metatarsal, but you can see how metatarsal angle varies in a lot. And this case could be the same. That is the one presented by Dr. Pascual. You can see arrows and faros, and you can see here the movement. So, to try to answer the initial question, where we place the metatarsal head, my experience, it is clear for me that the left position is not going to work, and the situation, the second one, the one on the right, worked poorly. But I don't know if in all the cases should be compressed that much because it exists the possibility that you can enlarge a little bit metatarsal. And I think that something important would be the stiffness of tendons and ligaments. As you can see in these graphics of deformation, so we can see two patients with a different curve of these connected tissues. So in a patient with this, that shows that this possible situation will need some bigger strengthening, a bigger shortening. But if the case round, so maybe we're not going to need this shortening because we're not going to have this stiffness. This made this work. That is an example. This arrows, we just press and we see that we can correct till this point. Oh, it doesn't work. Oh, it's a pity. I'm really sorry. But what we can see here, with the video we're trying to show is that the left one, so, so we can reduce deformity. Only to conclude, the objectives that I consider when I have to carry out the Harrison Vargas surgery, I try not to enlarge the first radius. I try to balance the strength and moments that are acting over the joint. I try to reduce the retrograde strength and hope that this strength or try this strength to be as much more parallel as possible as possible. So my conclusion is clear. We should think in strengths more than in angle. So we should so it is exactly the way. So because this strength would be the responsible for the relapse, possible relapse. And strength is not something you cannot see on CTs or X-rays. Strength is something you can explore. Thanks a lot for your kind attention. Thanks, Sergio. So those are explanations that will help us to approach our cases. And now we're going to give the floor to Dr. Amos Oxenam. He's going to speak about two surgeries on lapidus and little osteotomy, so to correct the torso with an excess of from the connection. Thanks for what you.
Bueno, la verdad es que voy a hablar en inglés. Y voy a hablar de las opciones de bunionectomía, es lo que me centro especial en la medicina deportiva y no hay mucha información sobre la cirugía en deportistas porque les da mucho miedo en caso de que luego no puedan volver a jugar. Y se describió por primera vez la osteotomía del Ludlow, se describió por primera vez en Alemania y en Estados Unidos es más conocida la osteotomía de Chevron o simplemente utilizan el procedimiento Lapidus. Uno de los primeros artículos científicos en el Lapidus en atletas fue descrita por el doctor Boucher y reveló que únicamente el 30% de los atletas pudieron volver a ejercer, a practicar el deporte. Y la verdad es que, bueno, llevó a cabo unos 200 Lapidus y en general a nadie le gusta, ¿no? Que tener esta no unión de los 11 casos de los 175 en total. Y se trata de dos tornillos y yo llevo utilizando muchos años placas y la verdad es que son más estables y llevan a una mejor fusión. Y quizá es indicado especialmente para los pacientes con osteoporosis y muchas personas creen que puedes deambular mucho más rápida en Alemania. La verdad es que, bueno, intentan que los pacientes empiecen a caminar lo antes posible y por eso es por lo que empecé a utilizar estas placas. Y bueno, estuve comparando los tornillos y las placas durante varias semanas y también estuve comparándolo con el lápido, si no había muchísima diferencia. Y una cosa que descubrí es que si alguien que no es capaz de mantenerse en pie, mantener el peso del cuerpo, muy a menudo desarrollan osteoporosis o tienen osteoporosis, que normalmente temporal y quizá esto es el problema o la razón de la no unión y si las personas empiezan a caminar lo antes posible en 4 semanas es mucho más beneficioso. En mi estudio en la comparación de placas y tornillos y aquellos del tornillo uno no tenía unión y dos pacientes con osteosíntesis sintomática debido a una rotura. Bueno, el otro caso ya lo podían ver ahí. Si echamos un vistazo a los criterios para llevar a cabo un procedimiento Lapidus en los Estados Unidos ha sido muy popular llevar a cabo este procedimiento en cualquier tipo de paciente y os explicaré por qué. No he tenido ningún caso de alus varus, sí que he tenido bueno, y la verdad es que además he tenido un seguimiento bastante largo de unos 3 años después y no hubo diferencias en las estadísticas entre los dos grupos. Así que estos son las típicas placas con 3 tornillos, plantar con tornillo de tracción y la procedimiento Lapidus. Esto es, bueno, este es la posoperatorio. Pero es un paciente diferente. Y La cabina de interpretación se disculpa, tenemos problemas técnicos que esperamos que se resuelvan lo antes posible. Bueno, y bueno, cuando hablas con un paciente, le preguntas que si quiere que tenga tener el dedo completamente recto, si quiere poner tacones, quieren hacer yoga o correr. eh, Son atletas y hay muchas variables dependiendo de los pacientes y tienes que preguntarles cuáles son sus objetivos y tienen que ser realistas. Más o menos lo que consigo es un 15% de los casos retiro la placa. Este es un ejemplo, simplemente la placa. Uno de mis compañeros que habló antes, Mafuli, llevaba a cabo intervenciones en deportistas y hay muy poca literatura publicada, y, sobre todo en temas de tobillo. Y este es uno de mis artículos científicos del año 2000, lo ven ahí el último de todo, el 2000, 2013, y el procedimiento Lapidus es muy popular, pero también conlleva grandes problemas. Y la verdad es que yo no participo en cuando se denuncian a algunos médicos y algunos de los casos más comunes es que desencadena una denuncia es el acortamiento del metatarsiano. Yo he hablado como con 2.000 médicos en 35 años de carrera y me han dicho que habían tenido todo tipo de cirugías de espalda y que habían llevado a cabo y solamente eh, hablé con un médico que me dijo que llevó a cabo esta fusión de la primera metatarsofalángicas. Y si no hay muchos médicos y cirujanos, podólogos que no han llevado a cabo esta intervención es porque no es muy recomendable. Esto, bueno, la verdad es que lo he traducido con Google Translator y, bueno, pueden ustedes sacarle una foto, pero básicamente lo que se dieron cuenta es que mejoraron y falsearon a la alza los resultados de este estudio. La mayoría de las personas, si tienen una fusión de la primera metatarsofalágica, y con una fusión a veces funciona, pero tienen más dolor y más limitación. Así que, bueno, la verdad es que a mí se me da bastante bien la estadística y creo que estos números no son reales. Así que les animo a que no se crean todo lo que está escrito, especialmente si está redactado en inglés. Y aquí tenemos otro procedimiento que la verdad es que sí, bueno, pues hay gente que hace mucho dinero con esto, los hospitales, los médicos, y hay un pequeño sesgo financiero y yo creo que la verdad es que no funciona para el pie. Pero bueno, en conclusión, para los atletas y los que quieren mejorar su actividad física, no hay ninguna prueba de que sea un procedimiento mejor que el otro y hay que tener cuidado con las complicaciones, este acortamiento del primer metatarsiano. Y bueno, no sé que quieran hacer peregrinaciones, hay un montón de maneras de llegar al mismo sitio. Todos los caminos llevan a Roma y bueno, hay diferentes opciones, pero hay que analizar bien y elegir el procedimiento adecuado. Y bueno, pues aquí tienen algunas fotos de mis compañeros, así que nada, muchísimas gracias. Thank you very much, Dr. Exano. Thank you so much. Some of your Saxena, thank you very much for your presentation. Maybe we have a couple of minutes for questions. If anyone here in the audience would like to ask any question, please raise your hand. And well, I wanted to ask Dr. Bernal Kavistan, based on his experience, he has some cases where the plate has been repaired with a whale and treating stability in the metatarsophalangeal. So, what is your experience in long term with the joint with these procedures? Yes, this is one of the main problems, and we don't have many tools that help with stiffness. And it's true that when you find there is a lot of material, and sometimes we're in risk of finding a rigid and stiff joint. So there's a tendency not to treat the plate, the whale osteotomy, and how to let or prevent the plate from having more function. Symptoms also, but not a function. So at least we need to use a lot of material sometimes. So we have a risk of generating more fibrosis, which is difficult to deal with. So it's mainly or probably one of the causes um, for recurrence, so or relapse. So it's I think it is worth trying to repair if running or have there is some stiffness risks. Thank you so much. Any more questions from the people in the audience? Then I will ask the Dr. Sergio Mirages. I'd like to know in those cases with patients with bunion and you consider a bunionectomy. So what factors do you take into account? Can you hear me? Yes. Well, when we have increase of subtalar pronation and collapse of the internal arch, we have an increase of the tension of the plantar structures, in particular the plantar fascia, which in terms will end up in an increase of the retro retrograde force or retracting retrograde force. But the thing is, I always want to leave both feet with the same pretty much shape. But when we perform jack test in one, it can be done with very easily, even though there's hallus valgus. But then in another patient, it can provoke some resistance. In some patients where I spot high resistance and high retrograde force in the metatarsophalangeal joint, I consider balancing that retro or hind foot and alleviate tensions of the retrograde force from the plantar fascia on the first uh, toe. So my last question to Javier, Dr. Javier Pascual, he mentioned that we needed to shorten the feet, the foot, the toe, um, depending on the deformity. But how do you calculate this? Do you do this? How do you assess this? How much, and how do you measure how much you need to shorten it? Well, I'm open for suggestion actually, because sometimes it is not easy because at the moment the implementation hasn't been able, I haven't been able to do it 100%. So maybe someone here in the audience can give me a better idea. And if you do, please share it with me. But what I do is if the foot or the toe of the foot is in an in claw, I try and move it around, and if the difference, say, once I try and I and revert the deformity, if it's about 6 inches, that is uh, one critical aspect, and then we need to do some ultrasound, and so I'm open for suggestions really. If anyone has a better idea of how to do this is how I do it. As pre-op, what I do is I try to open the toe, and then I measure it, and that's when I make the decision of how much do I shorten it. And now we have a question from the audience. If you can please bring the microphone. So I have a question for Dr. Dayton, no, Dr. Saxena. Last year, Dr. Dayton and Saxena explained they always defended the arthrodesis of the metatarsophalangeal joint because they said it was better to have one surgery rather than having two. So they always preferred to do fusion in order to avoid second surgery. So I'd like to know your opinion on this. Cuando tienes una lesión de la rodilla, no pones un implante directamente. Entonces, lo que haces es que rellenas. Entonces, como vemos en la diapositiva, eh, bueno, pues estas estadísticas que se veían, estos datos estaban equivocados y decían que tenían el doble de aumento de actividad del que realmente había, ¿no? Y si hubieran eh, y bueno, si hay un trauma previo, lo que voy a hacer es fusionar, pero no voy a hacer fusión en todos los pacientes porque eh, que lo puedas hacer no quiere decir que el paciente lo necesite. Pero tengo mucha experiencia en lápidus, en mis pacientes, pacientes de otras personas y en fusión de dedos. Y, por ejemplo, recuerdo una mujer en California, una mujer californiana, te odiaría si hicieras una fusión porque ya no podría ponerse tacones o sandalias. Entonces, bueno, esto hace 14 años recibí una paciente la y bueno, no era muy activa cuando era adolescente, pero ahora, por ejemplo, que ya casi tiene 30 años, quiere hacer más ejercicio, perder peso, y ahora es cuando viene a pedirme explicaciones de por qué le hice esta fusión metatarsofalángica, porque el lapidus no se puede deshacer. Así que bueno, yo diría, es mejor no hacerlo la primera vez que alguien viene a vernos. So I have a question. My name is Jordi Mariel. I have something I'd like to ask you, and I don't mean to. Uh, well, I mean, when we talk about bunions and there's a lot of young people here, and so let's say we have a bunion, a flat foot. What is it more important, the hind foot or the forefoot? Are we doing so? What can we do? We cannot do hind foot because we're not ready yet, or we don't do hind foot because the procedure as such is difficult, or because of the procedure of hallux valgus with the hind foot is going to make the surgery more expensive, and maybe that patient would not take it. So this is a question that we're wondering for a while, and we should not forget the biomechanics aspect and also the integral aspect, holistic aspect. Thanks to our specialization, we need to tackle the hind foot in forefoot interventions. Yes, I agree with most of what you're saying. But in my usual practice, I see when I tackle that hind foot, and I would never go through surgery if the case was a flat feet or a valgum feet. And the only thing is that if it was so more, if it's not a valgus or a flat foot, and so if I see it has an impact in the hallux valgus, that's when I suggest correction of the hind foot, just to try and get it as functional as possible and as lasting as as possible. And so I would never um, um, go through or operate someone with flat foot. And so then I do consider surgery when there is a severe deformity. That's when I consider fusion of metatarsophalangeal joint, because they probably would, just to prevent the bunion to develop. I mean, I don't know if I answered to your question. I think we're talking about different forces, moments in pronation, and it's not about talking about flat feet or valgus feet when they want to have a insole to help hindfoot reduce the strength, them having to do strengths. Well, thank you very much for your question. I think it was very interesting. However, due to lack of time, we cannot keep talking. We need to end up here. Thank you to all the panelists for the presentation. Thank you very much to the audience for the questions. And just to remind you, next year, the conference is going to take place in the Canary Islands. There is a stand with information regarding the conference next year, and we will raffle 3 free tickets to the conference. And so, having said this, thank you very much and see you in our next panel. Thank you.